you, sir?
Hello.
Hello. I think it's a bit.
Hi, Krishna.
Mohan, okay.
No, we are here. People are entering.
Mohan, this is a very awkward time to have a meeting. 2 o'clock. User friendly evening or so.
We can make it evening. Evening come. പലരും കോളേജിൽ നിന്നല്ല ഹോസ്പിറ്റലിൽ നിന്നുള്ള അതുകൊണ്ടാണ് പറയുന്നത്.
Radiology clinicians, gynecologists പ്രത്യേകിച്ചും, they have no control over the time. അല്ലേ പൈലി സാർ?
Hello, Shaji.
Hello, sir.
Hi. Congratulations. I heard that you have taken over.
Dean Research.
Yeah, I heard that. Congratulations.
Thank you, sir.
That's very good.
We will try and change this timing. I think generally it should be better because evening after 7 or 7:30 p.m. is better. Not that it's convenient for everyone, but then it might be much better than this.
But as we see, Mohan said, with many of the non-medical faculty, maybe during their professional hours only they will be logging in, isn't it? Working hours.
That's one issue, sir, because if you were to include people who are working, then maybe 3:30 to 4:30 may be even better, because this is a lunch break kind of situation, which is sometimes getting delayed. Late lunch, many people will be on their way back after lunch.
Hello, Vijay. Nice to see you.
Hello, sir. Sir, രാജഗിരിയിലാണല്ലേ?
അതെ, രാജഗിരി.
എനിക്ക് ഇവിടെ നെറ്റിന് എന്തോ പ്രോബ്ലം, അതുകൊണ്ട് ഞാൻ മൊബൈലിൽ കയറിയിരിക്കുക.
ശരി. യൂണിവേഴ്സിറ്റി തന്നെയല്ലേ ഇപ്പോ?
അതെ, യൂണിവേഴ്സിറ്റിയിലാണ് സാറേ. എന്റെ റൂമിൽ നെറ്റിന് എന്തോ പ്രോബ്ലം, അതാണ്.
സ്കൂൾസും സെന്റേഴ്സും ഒക്കെ ഇങ്ങനെ ഒരു ട്രാൻസ്ഫോർമേറ്റീവ് സ്റ്റേജിലാണ് സർ. അത് ഒന്ന് ഓർഗനൈസ്ഡ് ആയി വരണം. അതിനിപ്പോ റിസർച്ച് അസിസ്റ്റൻസ് ഇല്ല, കുറച്ച് ഫാക്കൽറ്റി ഇൻചാർജ് മാത്രമേ ഉള്ളൂ.
ഇതിന്റെ
ഓറഞ്ച് എടുക്കട്ടെ ഞാൻ?
ഈ കോഡിന്റെ ആണോ എന്നുള്ള അറിയില്ല. അതല്ല അല്ല, ഈ കേബിളിന്റെ ആണോ അതോ അതൊക്കെ ഉണ്ട്. അല്ല, ഇവിടെ ഇരുത്തലേക്ക് നെറ്റ് കിട്ടുന്നില്ല, അതാണ് കൊടുത്തിട്ടേ.
വിജയൻ വേണേ വിജയൻ.
ഹലോ സാർ, പറഞ്ഞോളൂ സാർ.
മ്യൂട്ട് ചെയ്തോളൂ.
ഇവിടെ നെറ്റ് റെഡിയാക്കാൻ പറ്റുമോ നോക്കുവരും.
ഹലോ സാർ, വിജയ സാറേ, വൈദ്യ സാറേ, ശ്രീദേവി.
ഗുഡ് ആഫ്റ്റർനൂൺ മാഡം.
ഗുഡ് ആഫ്റ്റർനൂൺ സാർ, വിജയൻ സാർ ആൻഡ് വൈദ്യ സാർ.
ഹായ് ശ്രീദേവി.
ഞങ്ങൾ എല്ലാരും ഇവിടെ ഇരിപ്പുണ്ട്, ഡിപ്പാർട്ട്മെന്റ്.
വെരി ഗുഡ്.
നമ്മളിവിടെ ഹോസ്റ്റ് സുഭദ്ര ഹാസ് ഗോട്ട് സം ടെക്നിക്കൽ പ്രോബ്ലം, അതുകൊണ്ടാണ് വിൽ ജസ്റ്റ് സ്റ്റാർട്ട്.
അതെ അതെ സാർ തുടങ്ങിക്കോളൂ.
വിൽ ജസ്റ്റ് അല്ല ജസ്റ്റ് വിൽ വെയിറ്റ്, ജസ്റ്റ് സുഭദ്ര ഒന്ന് സ്റ്റാർട്ട് ചെയ്ത് കഴിഞ്ഞാൽ.
ഇല്ല, ലാപ്ടോപ്പ് മാറ്റണം എന്ന് പറഞ്ഞു, തുടങ്ങിക്കോളാൻ പറഞ്ഞിരുന്നു. ഇപ്പൊ വിളിച്ചിരുന്നു എന്നെ. ഒരു ലാപ്ടോപ്പിന് എന്താ പ്രോബ്ലം ഉണ്ട്, മാനേജ് ചെയ്യാൻ പറ്റുന്നില്ല. ലാപ്ടോപ്പ് മാറ്റണം. അതിന്റെ ഇൻ ദ മീൻ ടൈം ഷീ വിൽ ജോയിൻ. If you could start, that will be great.
Okay. One second. I just confirm. So shall we start? Well, sir, yeah.
I think so.
Very good afternoon to all. Respected Professor V.P. Paili, a great teacher and a great activist in the field of public health. Dr. C.P. Vijayan, the Pro-Vice Chancellor, Professor Shaji, Dean Research, Professor Krishnan, Professor Ambujam, and esteemed faculty members, respected ladies and gentlemen. We are continuing our series of webinars on problems of the aging population. In fact, our original idea was to conduct physical meetings in multiple locations in Kerala. And we had our first meeting with the help of Professor Krishnan and Baby Memorial Hospital at Calicut. And there everything stopped because the COVID came. But then we realized that this new technology, the virtual meeting, is also good. Now many of us sitting in various places could meet and discuss, and we can arrive consensus. I'm extremely happy that Professor V.P. Paili is with us. He is the doyen in the field of obstetrics and gynecology, a great teacher, and I had the fortune to work with him in Thrissur Medical College for a long time. And his contribution, especially in the field of reduction of maternal mortality, is phenomenal. and he, with his team, has done tirelessly for reducing the maternal mortality in Kerala. Even though it is less, it has been further reduced by Professor Paili and team, and he continues to work and teach and continue to do surgery also in Rajagiri Hospital. Welcome, sir. Welcome to this webinar. And problems of aging, why university is concentrating on that. In fact, that is the biggest health challenge of Kerala state, and almost 14% of Kerala is above 60 years, and the national average is just above 9%. So it's a problem Kerala has to tackle. And also, among the aging population, that is among the 48 lakhs of people above 60, 80, 15% are above 80. So that's a very huge burden. And Kerala is the only state where the female population is more than the male population. Rest of India, with the current practice of female feticide and everything, males are more. But Kerala is the only state where the female population is more. And when you when you count the number of females in the age population, and that's a very huge number. In fact, the life expectancy of a male is only 72, and that of a female is 77. So naturally, the age population of females will be more. In many homes, we have only a single old lady, and she is having various problems. And how to tackle that? That is a huge burden, and university definitely understands that, and we are planning to conduct various research studies and suggest solutions to the government. And I'm very happy that our new Dean of Research, Professor Shaji, is a person who has done a lot of research in that area, and definitely we will be contributing to improving the Kerala's health. And I am very happy to inform all that government of Kerala in the last budget had made two announcements. Number one, Thrissur Medical College has been declared as a campus college of the university. This is a very unique statement. I don't know whether anywhere in India such a situation exists. So we have to evolve and convert a medical college a part of the university system. And another thing is that after when we are living with COVID, and after the history of Nipah, government has realized that an epidemiology center is essential in Kerala, and the announcement came in the budget in the name of Dr. Palpu, a great doctor who saved thousands from plague. So Dr. Palpu Center of Epidemiology will be established in the university campus. And in fact, I would like to inform one happy news, that our honorable finance minister visited the university yesterday and had discussion with the university officials regarding the establishment of Palpu Center. So I'm very happy to inform our faculty and our colleagues that the university is going ahead, and these webinars are part of that. And we will definitely document the discussions happening here, and that will be percolated to the scientific community. With these few words, I declare that today's webinar is inaugurated, and I welcome Professor V.P. Paili, the great teacher, to teach us what is the situation now.
Thank you very much. Thank you, Professor Vijay, the Vice Chancellor, and other colleagues, Shaji and Vijayan and Sridevi and Krishnan. It's a great honor to be asked to talk about this problem. And the background has already been mentioned. Dr. Mohan already told us why the female population, being the dominant or more of them surviving, we have more likely problems from the gynae side as well. So it's a very relevant, a topical issue to consider the gynecological problems in this age group. And that's why I thought I will deal with it. But I inquired a little while ago as to who the audience will be. And of course, it's not a pure modern medical audience. So it will be a general overview of the problems and the approach that we have to some of them in detail. So that's how we have planned it. Can I have the share screen, please? Yeah.
It is more in the sacral region. It is present when the patient ambulates and reduces on supination. Therefore, treatment can be used for pain is due to stretching at the nerve fibers and uterus. Adults have fertility and no sexual symptoms, reduced sensation and arousal. Mechanical, huge prolapse umbilical.
There is sound disturbance from some other.
Infection in the vagina, the cervix can be caused.
I request everybody else to go on mute.
Away from the external
Please.
The mechanical factors endometritis and low-grade infection.
Okay. Audible? The gynecological problems in the geriatric age group is how the topic was put. But then I feel that probably it would have been more appropriate to call it as the aging problem, aging population, or the mature women, because I hope I am audible.
Very well, sir. Very well. Very well.
Okay. So we will probably capture it as the problems of the aged or the mature women, because geriatric has a connotation of old people, and many people don't like to be called old. They always would like to be young. So from that one, I would put this as the gynecological problems of the mature woman rather than the aging or the aged or the geriatric. But the physiological basis of gynecological changes in the mature woman is the change in the ovarian function. As all of us know, femininity itself is decided by the amount of estrogen circulating in the body. Estrogen is coming from the ovary, and the ovary is controlled by, as all of us know from the very early days of our medical studies, a complex axis is existing. That is, I'll come to that once again, existing, which starts from the brain, the hypothalamus, the pituitary, ovary, and of course, the hormone coming out of that. So that is how it is. And the outline of my talk, I thought we would consider the transition that happens at the menopausal age, the problems related to deficiency of the ovarian hormones affecting the various organs in the body, how the hormone deficiency can be overcome by the menopausal hormone treatment, what specifically are the problems related to the genital tract, like dryness and atrophy, and probably a little more emphasis on genital prolapse and urinary problems, especially incontinence, and then the main concern that is there in the older aged women, malignancies, which may affect the cervix, the endometrium, the ovary, like that. So this is how I thought we would cover the points I wanted to cover under this heading of geriatric, the gynae problems in the geriatric age group or mature woman. Coming to the menopausal transmission, it is age related. It doesn't have a specific age. When does menopause occur? Menopause is the cessation of menstruation. And it used to be, when we started our medical career, we used to say 45. But now the average is certainly more than that. In many studies, they say it's up to 51. And it is a reflection of the social standard of the community. In Kerala, for that matter, our average is about 49. That is how we think it is. But it can be, in the West, it is almost 51 now. It's all related to the follicular function, ovarian follicular function. And the follicles, which are in terms in millions, as the ovary forming, this accretion of the follicles start even in the intrauterine life. So aging of the ovary is starting even before birth. And If you look at it, this is the axis I was referring to. The brain and the hypothalamus over there, which controls the pituitary or the hypophysis as we call it, which works on the ovary, and from the ovary, the estrogen comes. So the transition that happens at menopause is not an abrupt event that happens one day. It's a change that happens over years. For about 6 to 7 years before the final menstrual period, FMP as they call it, actually the changes of menopause start. It may start with a change in the pattern of menstruation. To start with, there may be more frequent periods, but later intermenstrual number of days slowly increases and finally it stops. Very rarely only an abrupt stop of the menstruation happens. Very often it's a transient increase in between menstrual cycle, the days, and finally it stops like that. So that's a menopausal transition that happens as a result of the change of the stimulus that comes from the hypophysis to the ovary and the hormones that come out of the follicles in the ovary. The reduction in the follicles bring about deficiency in the amount of hormone circulating, especially estrogen. And also there are changes from the ovary where the follicles do not send out that much. From the stroma, there may be other hormones coming and androgens may marginally increase at that age. The effect of the estrogen deficiency, most commonly felt by the woman, is the vasomotor symptom. We'll come to that once more. But along with that, the estrogen deficiency leads to genital and breast changes, atrophy. All parts of the body are affected, but skin also reflects very much the change that is happening in the estrogen level. Now, the vasomotor symptom is mediated through the hypothalamus. Hot flashes and night sweats are the symptom that the woman will complain. When it happens during the night, it can disturb the sleep. Along with that, the calcium deficiency, because metabolism is very much influenced by estrogen, and the bone calcium content comes down, and the chance of fracture, the female, both male and female, geriatric age group, but all the more so in the female. So the chance of fracture happening is small. The other changes that happens with the estrogen deficiency, mainly related to the genital tract. If others could mute their microphones, please, because there's a lot of disturbance coming. The problem happens in the genital tract is atrophy of the genital tract. The squamous epithelium that covers the vagina is actually usually 30-40 cell layer thick, but it can come down in the thickness and that leads to atrophy. The secretions that come in the vagina become less and that leads to dryness. Because of this, there may be dyspareunia, that is the painful sexual contact, and also there will be loss of libido. So these are the changes that happen as a result of the estrogen deficiency in that age group. And the treatment for that is to replace hormones which are deficient. As we said earlier, the main agent that is deficient is estrogen. So we can think of replacement of estrogen to counter the effect that has come out of the deficiency of the estrogen. So, but if you give estrogen to a woman in her menopausal age, if she has a uterus, the menstruation that stopped may restart. That's again not a very welcome change. So to avoid that, to avoid the endometrial thickness coming back or the endometrial hyperplasia that can occur, we have to counter it with progestins also. So whenever we think of menstrual as menopausal hormone treatment, if there is no uterus, no harm, only estrogen is required. But if the uterus is there, we may have to suppress the estrogen hyperplasia by adding progestogen also along with that. And sometimes even androgens are added to increase the libido. So the menopausal hormone replacement is mainly with estrogen. In those with uterus, may combine with progestogen and sometimes even androgen. The estrogen that was commonly used until a few years ago was conjugated equine estrogen. But of late, 17-beta estradiol is the one that is being promoted as the best agent. The progestogen that used to be given along with estrogen used to be medroxyprogesterone, any of the synthetic progestogens, but now micronized progestogen is the one that is favored. So estrogen and progestogen replacement at this age group will help to reduce the bad effects of hormone withdrawal that is happening. And that is the first thing that you have to think about the menopausal hormone treatment and as a replacement of the estrogens. This next problem that is a result of the changes of the menopausal transition is the weakness of the supports the genital tract. As all of us know, the uterus is actually suspended. It is kept in its place with a complex mechanism. It has got ligaments and fascia, but it is resting on the muscular base in the pelvis. So when the ligaments and the fascia get weak, the organs that are kept in its place will start to bulge. This is, as many people say, a price to pay for the erect posture that we have. And when the ligaments as well as the fascia get weaker, the organs supported by them will begin to sag. That is basically the problem that happens in the genital tract. And the sagging can happen, as we call the genital tract, we call as different compartments. There is the apical compartment or the level 1. There's a middle level or the level 2, and the lower one or the level 3. Usually it is not an isolated one. There may be a combination of the different ones. But the apical and the middle compartments are the significant ones, not the lower one. And if you look at it as a pictorial representation, if you look at it, that is the uterus and that is the level 1. So if this comes down further through the vagina, we will call it a level 1 defect. And what is holding the cervix and the uterus above that in that place is a pericervical ring of fibrous tissue. But the more important thing is that the uterus is anteverted and there is the levator ani as the base of a trough, and it is supported by the muscles over there. When the muscles get weak and the ligaments which attach it to the sacrum posteriorly and to the symphysis pubis anteriorly and to the side posteriorly towards the side of the sacrum, when all these ligaments get weak, this will come down. And that is the basis of the prolapse of the level 1. When it comes to the level 2, from there to here, anteriorly, if you look at it, it is the bladder over there. So if the fascia that is over here gets weak, the bladder will bulge down. If the fascia in the lower part get weak, the urethra may bulge. If the fascia here on the posterior wall get weak, rectum will bulge in. Along with that, I should mention that if the level 1 over here is weak, this thin separation from the peritoneal cavity to the vagina get weak, this will come down along with bowels in that. We call it an enterocele. So the level 1 and the level 2 are the most common sites of prolapse related to the older age. Sometimes we may have even the perineum to bulge down or to sag down, and anteriorly the suburethral region also bulge down. But that is not clinically the major issue. So pictorially, if you are to represent, This is the bladder coming down as a cystocele. This is the rectum coming down as a rectocele. This is the apical part coming down, which we call a cervical descent. And if this part is coming down, we call it an enterocele. So this is the major problem that we get. In this particular patient, as you can see, she has got the total eversion of the vagina. The cervix is leading. This is not as a result of the prolapse alone. This is just epithelial denudation over there. But this is the bladder bulging out. This is the cervix coming well below. So this sort of a prolapse makes life miserable for the woman. The bulge symptom is the main problem they have. But along with that, it will affect their sexual contact as well. Whereas, as you can see here, what has happened? See, it started to get ulcerated. It may rub against the clothes, so it gets ulcerated, and it can also start to have discharge much more, and it can get infected. Here you can see it's already a healing ulcerated part of the prolapse. In fact, in this patient, the cervix is not there. Uterus had already been removed, and it's the whole vagina which is inverted, with the apical part of the vagina, that is the level 1, leading here as the leading point. So this we call a walled prolapse. This is another example of a walled prolapse in somebody who had actually uterus removed. You can see that dimple over there is in the right place. But this is the anterior compartment which is coming down with the bladder along with it. So it's actually a cystocele. But for practical purposes, any prolapse that happens after the uterus is removed may be called a walled prolapse. This is another example of a walled prolapse. And when I play the video, you can
had prolapse in pair
happened
3 months earlier, but had immediate recurrence and came.
So this actually is a beak-like projection of the wall to the vagina.
And extended
What had actually happened
towards the urethra.
This patient came out with
Bladder was separated
beak-like projection
from the vaginal walls. The section was extended posteriorly towards the peritoneal cavity so as to enter the enterocele.
So
The enterocele
example of a wall prolapse that happened soon after.
had prolapse in pair.
This is another example. As you can see, the whole bulge, anteriorly it is bulging out so much. The whole area had been lying outside for a long time, so it got pigmented. And as you can see, it's very distressing to the woman because the whole thing is bulging out. You may wonder why they waited this long. Here, as you can see, there is a walled prolapse. The whole vagina is inverted. But along with that, you can see the rectum also prolapse. Not at all very unusual because this is a total weakness of all the supports. Part of the rectal support is shared by the vaginal supports as well. And so whenever there is prolapse like that, we can have rectal bulge, as we can see here. So it's a rectal prolapse along with a genital prolapse, a combined prolapse as we call it. The space between the two demarcates the two. But here, posteriorly, this may be the posterior wall of the vagina bulging out. There can be circulation of the upper rectum into that as well. But this is mainly the cystocele that is coming out. In the middle here, there may be the enterocele. So genital prolapse as such is a very distressing one. And as you can see here, another case where there is a total eversion of the vagina with the cervix over there. And as you can see, well, I thought I will just show how we do the management of these cases. We have to not necessarily remove the uterus, but we have to make sure that we restore the anatomy back so that the vagina doesn't become something which is everted like this. Vagina is being taken back to a deep canal so that it will take away the distress for the woman of something bulging, as well as to allow her to have normal sexual contact. So what we do here as the first step is to get the uterus removed, and we are going to do the hysterectomy here. Once the uterus is removed, as you can see, that is opening to the uterine, to the peritoneal cavity. So we are closing off the peritoneum. How we can get the vagina to go back after that is question. What I am going to show you here is something which we do very much here, use of a mesh, which is the same type of mesh but much more softer and macroporous that is used by the general surgeons when they repair a hernia. But here now we are dissecting the bladder. That's the bladder over there, being separated from the vaginal walls. And we have to get that bladder up. Then we open the vaginal wall posteriorly and then dissect and get the rectum go back and get a plane between the vaginal wall and the structure behind it, anteriorly the bladder and posteriorly the rectum. So once we are taken to that level, so what we will do next is to get a mesh. So this is the very macroporous, very soft nylon or proline, as we call it, proline mesh that we are going to introduce and get this whole vagina go back, invert. And the mesh is kept because just like the surgeons have found out that hernia repair is more durable with lasting results, we use a mesh. All the more here because the supports are very weak, and that is how it has come out. So what we are going to do is interpose this mesh inside so that anteriorly the bladder will be supported, posteriorly the rectum will be supported, and at the apex, the small bowel will be prevented from coming down, the peritoneum will be prevented from coming down, and now what we are going to do is, along with that, taking the mesh to the side and supporting it there, and finally, once we have got and we can suture the vaginal walls so that it becomes, so we are just closing off the posterior vaginal wall. And as you can see, she's got a deep vagina there. She has got support for the bladder. She has got support for the wall to the vagina or the level 1, and she has got support for the rectum. So this is what we do a lot in massive prolapses like that. But if the prolapse is not massive, we don't have to do that much. What we do in such cases is utilize the fascia and the ligaments and then support it. Procedure is almost similar to what you already saw, but then whatever has been latched and stretched, we may trim it. We may take it back to the durable structures in the pelvis. For that matter, we have ligaments which are stronger. One of such ligament is sacrospinous ligament or the pre-rectal ligament, pre-sacral ligament or the uterosacral ligament. All these structures are used for supporting. With a younger woman, where we want to retain the uterus, what we'll do is we will take away the elongated hypertrophied part of the cervix only and get the uterus back and support it again with some strips of mesh into structures at a higher level. We can support it to the pre-sacral ligament. We can support it to the inguinal ligament anteriorly. We have also got procedures where we can support it to the anterior abdominal wall. Whatever it is, with one structure or the other, we are making the anatomy back so that they can retain the sexual function as well as for the take away the inconvenience of something bulging from the vagina. And also in case of younger women, we will put it back, the uterus back, so that it can allow them to have pregnancy as well. So this is how we tackle prolapse most of these times. The mesh which I showed you is not at all that universally accepted at the moment. It was promoted a lot by the companies which manufacture these products. And as a result, it started to be used without proper training and a lot of complications happened. As a result, what has happened now is in the West, America, UK, part of France, and Australia, the use of mesh vaginally, as I showed you, is not allowed. But in some of these countries, but more so in the Asian countries, Singapore, Thailand, Taiwan, and even China, we are still continuing to use the mesh, but the ready-made set or kit which were produced by the companies are withdrawn. So that is how the prolapse is treated at the moment. We I mean, personally for me, as well as many in the Asian countries, including Singapore and Taiwan and Philippines, Indonesia, in all these countries, they still plead that selectively and properly used mesh adds to the durable result of the prolapse surgery, and so we are continuing to promote it. So that is the way we manage prolapse in these age groups. But what we used to do earlier was, as those of you who are trained in the modern medicine, remember, we used to repair the bladder, support the bladder by anterior colporrhaphy, support the posterior vaginal wall by doing a posterior colpoperineuraphy, and sometimes people used to do a very tight perineuraphy, as you can see here. Perineum has been tightened so much, so the hole is very narrow. This can even lead to dyspareunia. So this is no more recommended. But in the very elderly age group, we cannot stand a prolonged surgery. The mesh surgery, which I showed you, usually may take about an hour and a half. If you are using supports of the ligaments, which I mentioned, it may also take about an hour and a half. But if we cannot allow the woman to go through such prolonged procedures, we can even just invert the prolapse part and then close the vagina off, what we call a Leaford surgery. But it's not a very popular operation in the, except for those who are very debilitated and young. The other method that used to be popularly followed was use the pessary for prolapse. The place of pessary is not all that much in our practice. In the West, if you look at it, pessary is very much popular. The elderly age group there have the pessary put in, and there will be regular visit by the health workers to home to make sure that the pessary is taken out, cleaned, and reinserted and all that. In our country, such facility is not available regularly. So the ring pessary, for that matter, is put in. That will be even forgotten, and later to erode into the vagina and ulcerate and all that. So we are, in our practice, not using the pessary so much, except for those who cannot consider undergoing the surgery. So that is about the management of prolapse, which I thought I'll bring to you. The next issue that comes along with prolapse, or even without that, in the older age group is urinary incontinence. Urinary incontinence, basically we can talk about two types. One is, as we call the stress urinary incontinence. What it means is, whenever intra-abdominal pressure goes up, any stress, any strain, like even jumping, coughing, sneezing, climbing stairs, will make some urine escape. Small amounts, but that may be enough to soil the clothes, and it can be disturbance, and it can even alter the lifestyle of the person so much. She may then stop going even socially outside. This can affect their total happiness as well as activities. The second type of incontinence that we get are due to overactivity of the detrusor muscle of the bladder, so that the moment they think about going to toilet, overactivity happens and escape of urine occurs. We call it urge incontinence. These are the two types. The treatment for the urge incontinence is to suppress the detrusor with medication. And we do that with medicine like difenacin or other drugs that are available. But if it's a stress urinary incontinence, at the moment, the preferred mode of treatment is to support the mid-urethra, that area, with a mesh piece, so that it will bring back the angulation that is there at the bladder neck between the bladder and the urethra. So this is a small clip of how we do this constrictor, like how we do the mesh placement in the mid-urethra to take care of the stress urinary incontinence. What we do here is, after infiltrating that area, we make a vertical incision, expose the suburethral area, and then take a piece of mesh, similar mesh as I showed you a little while ago, and allow that mesh piece to come and be placed under the mid urethra. So we use a trocar to take the mesh. A strip of mesh about 1 centimeter wide is then, as you can see, this type of a mesh is then taken to the trocar point that you saw on the side. So actually on the side over here, it is going to be taken out through the obturator triangle. So this trocar will pull that mesh piece back in and bring it out to the obturator on that side. The same thing is then being done on the opposite side so that it comes out on the right side. And the mesh is then allowed to stay just under the urethra over there, and you close it off. So the excess mesh on the sides are cut off. So we have got the small opening that we made under the urethra being closed, and this will give support to the urethra whenever the woman coughs or sneezes or jumps or walks brisk. The escape of urine that was bothering her will not happen. And so that is the treatment for the stress, the incontinence. Another distressing problem to many women in the geriatric age group. So this brings us to the more worrisome problems of tumors and malignancies in this age group. All parts of the genital tract can be affected. It includes the cervix and the myometrium of the body of the uterus, the endometrium, ovaries and tubes, we take them together now. Vagina, vulva, all these parts can be the seat of tumors and malignancies that can be a problem. Tumors can be benign, but mainly related to benign ones, mainly related to ovaries. It can be tumors related to the myometrium of the uterine body, mainly fibroids. But the good thing is, when the estrogen activity in the body gets less and less at menopause, the fibroids usually regress. If there is increasing size of a fibroid in the postmenopausal age group that we are considering now, it can be due to malignancy, and such fibroids are better removed. If it's a fibroid, as you can see here, that's a cervix. So this is fibroid extending to both sides. If it happens in the postmenopausal age of this group, this size, we may have to better remove it. But a large one like this, growing retroperitoneally, this is the cervix, and this, you see the large fibroid going retroperitoneally, and if it is growing and remaining persisting, or ultrasound shows you vascularity, so you can see here that better come out, because we don't know whether it will be undergoing a transformation to sarcomatous change. But fibroids, by and large, menopausal or not, can be removed, and these days we remove them vaginally, as happened in this case, or with laparoscopic assistance. That's a service, this is other service. So we have bisected the uterus and removed all these pieces of the fibroid piecemeal to give a relief of this problem. That brings us to the problem of ovarian tumors. They can be solid and cystic. Any tumor in the ovary, any enlargement of the ovary in the postmenopausal age needs investigation. If they are cystic, large cysts need not mean malignancy. In fact, the opposite. Very large cysts in the ovary usually are not malignant, they are fairly benign. Anyway, malignancy can affect all parts of the genital tract. That includes the cervix, the endometrium, ovaries and tubes, vagina, and vulva. Cervical malignancy, that used to be the main type of genital malignancy, fortunately has come down. Even in Kerala, we see that it is so much less. Very rarely only we see a case of severe cervix. People will immediately think that it's because there's a vaccine available. It's true. Papillomavirus was identified as the trigger factor for development of carcinoma cervix. With that knowledge, we started to develop a vaccine. These days, we are all concerned about, are interested in the vaccine. But this papillomavirus vaccine became available more than 10 years ago. In developed countries, it is popularly and almost compulsorily being given to adolescents so that the carcinoma service as a problem, we hope will disappear. But in Kerala, even though papilloma virus vaccine is not all that much used, carcinoma service has come down. It's very seldom that we see a carcinoma service these days. What the mechanism was, we are not yet sure. But anyway, we all hope that with the vaccine being given at the adolescent for boys and girls, carcinoma service drastically will come down. It has already come down, but it will be much more. We hope that we will have a CA service free. It may not be total, but at least the burden that used to be a killer that used to be cervical malignancy will disappear. The most common malignancy that we gynecologists see in Kerala now is endometrial malignancy. Any bleeding that happens in the postmenopausal age, we have to be wary of. That has to be investigated and find out what it is. Not that any woman in the postmenopausal age bleeding is having a CA endometrium, but it needs to be investigated. Fortunately for us, ultrasound can be a good tool to identify what's happening. The thickness of the endometrium in the postmenopausal age is the key factor. If it is very thin and atrophic as it should be, maybe the bleeding can even be due to atrophic endometrium. But if it is any more than 5 millimeters, some people say even 4 millimeters in thickness, that should be sampled to rule out malignancy. And fortunately for us, sampling the endometrium is simple now. We have got a very thin tube which we can introduce into the uterine cavity and just suck with a syringe, sort of suck with the plunger, and we get a sample of the endometrium, which is almost 99% reliable to rule out malignancy. So that is the current situation regarding carcinoma of the endometrium, which unfortunately is the most common cause or type of malignancy of the genital tract in the female, as we see in our practice at the moment. Service has gone down so much. And of course, CA of the endometrium, if it's early case, that gives us the best result. So the good thing about CA endometrium is that it usually presents with postmenopausal bleeding. Once we have that symptom, if we investigate, we can find out the hormonal status or the status, the histological status. And if there are changes towards malignancy, you do remove that uterus, you get the best result. And surgical treatment is the mainstay for carcinoma of the endometrium, except when it is advanced, when we may have to resort to chemotherapy or radiotherapy. So basically, carcinoma endometrium, which is the most common type of genital malignancy that we deal with, of course, excluding breast, which usually gives warnings of bleeding very early on. Once we make a diagnosis, which is possible with just sampling the endometrium, and once you treat it with surgery, the results are extremely nice, extremely good, very encouraging. So even though this is the most common type of malignancy we deal with in the genital tract now, fortunately, the outcome is not all that bad because we get some warning with the bleeding. That brings us to the ovarian malignancy, which unfortunately is the major killer of all the genital tract malignancies. Ovarian tumor is the main killer. The reason for that is it's usually diagnosed very late. We cannot have a clue about it in the early stages. And by the time we diagnose it, it might have already been advanced, and removal of that may not give full relief. Clinical examination and investigations to clinch the diagnosis may give us a clue, but the early stages of malignancy may not have any symptom at all in the ovary, no symptom at all. And so usually, as I said, the diagnosis comes late. A large ovarian cyst like this, as you can see, large ovarian cyst like this, thankfully, may not be all that always malignant. Some varieties of ovarian tumors, like mucinous adenoma of the ovary, can grow to this size, even bigger, to kilos. See, 10s and 20 kilos size it can go. Unfortunately, they are not malignant, but they have other bad effects because of the size and the pressure. But the ovarian malignancy usually are the most common variety is the serous adenocarcinoma, and they do not usually present with very large masses, but before that it would have spread, and depending on the histological appearance, its malignancy also will vary. The earliest diagnosis, the better. Unfortunately, we don't have yet a widely applied screening test for that, but certainly ultrasound has made a big difference. Surgery is the main mode of treatment for these malignancies. And surgery means removal of the affected tissues, any secondaries, and very often followed by chemotherapy. Very early stages, it's microinvasion and all that, it may be treated just with surgery. But when it is advanced, or where there is reason to believe that cells would have gone beyond the ovary to the system, to the general pituitary cavity, then we have to treat it with follow up with chemotherapy. So chemotherapy is the second line, and radiotherapy probably the third line. So that is how the ovarian malignancy is coming up. So in these cases of malignancy of the ovary, earlier we make a diagnosis, better the results. But if the diagnosis is late, outcome is poor. So as an overview of the whole problem of gynecological issues in the geriatric age group or the mature women, they are significant. As our VC already said in the introduction, the population, especially female population in the state, is disproportionately more. We are almost like the Japanese. Our female age population is much more. And the ailments related to age are also going to be more. Fortunately for us, they are most of the time amenable to treatment, except ovarian malignancy, which usually is picked up late, and that makes the prognosis also bad. In all other situations, the common problems they come with, like prolapse, tumors in the ovary, other than malignant ones, for all these urinary problems, we have reasonably good treatments that will give their make their life more enjoyable. And that will be our aim, to make their life more enjoyable. But let me finish here. Thank you very much for this opportunity to share some thoughts about the problems, gynecological problems of the aging population. Thank you.
Thank you, sir. Thank you, sir, for such a wonderful session. ഓഡിയൻസിന് സംശയങ്ങൾ ചോദിക്കാനുണ്ടെങ്കിൽ ചാറ്റ് ബോക്സിൽ എഴുതി ഇടാവുന്നതാണ്.
I think you are muted.
No.
You are muted, so we cannot hear you.
Oh, sorry, sir. That's sound.
Comments?
Dr. Ragmohan.
Good afternoon. Good afternoon, sir.
I think there is a problem with the muting, because maybe centrally it's all muted, so I cannot hear any of you.
Okay.
Hi, Rajmohan.
Hi, sir. Thank you.
Kelkalo, I think Rajmohan.
കേൾക്കാമോ സാർ? സാറിന് എന്തോ കേൾക്കാൻ എന്തോ സാറിന് എന്തോ പ്രശ്നം കേൾക്കാൻ.
ബാക്കി എല്ലാവർക്കും കേൾക്കാം.
സാറിന്റെ ഓഡിയോ ഒന്ന് നോക്കൂ സാറേ.
ഓക്കെ, സാറിന് കേൾക്കാം. ഫോൺ വിളിച്ച് പറയണമായിരിക്കും സാറിന്.
സാർ ഓഡിയോ വെച്ചിട്ടുണ്ടാവില്ല.
Sir, thank you for the wonderful presentation. അത് പറയാനാണ് ഞാൻ
അങ്ങനെയൊക്കെ മാഡം പറഞ്ഞൊന്നും കേട്ടില്ല. ചാറ്റ് ബോക്സ് മാഡം പറഞ്ഞില്ലേ മാഡം? കേട്ടില്ല, നമുക്ക് ഇതായില്ല. Sir, am I audible?
യു ആർ ഓഡിയബിൾ, പക്ഷെ സാറിന് കേൾക്കാൻ പറ്റുമെന്നുള്ളതാണ്.
അതാണ് ഇപ്പോഴത്തെ പ്രശ്നം. പൈലി സാർ എന്താ പറ്റിയോ?
സാറിനോട് ഫോൺ വിളിച്ച് ചോദിക്കുക നിർത്തിയുള്ളൂ.
ഞാനൊന്ന് വിളിക്കുന്നുണ്ട്, പക്ഷെ സാർ എടുക്കുമെന്ന് എനിക്കറിയില്ല. ഫോൺ സാറിന്റെ കയ്യിലില്ല എന്ന് തോന്നുന്നു. സാർ എടുക്കുന്നില്ല.
പൈലി സാറിന്റെ ഇത് കാണുന്നില്ല.
സാറിന് നമ്മൾ മ്യൂട്ട് ചെയ്തിട്ടില്ലല്ലോ സെൻട്രലി?
ഇല്ല, അതാണ് ഞാൻ ചെക്ക് ചെയ്യുന്നത്, പക്ഷെ ചെയ്തിട്ടില്ല.
അല്ല ഇപ്പൊ നൗ സാർ ലുക്സ് മ്യൂട്ടഡ് ആയിട്ടാണ് കാണുന്നത്.
അതെ, പക്ഷെ ഇവിടെ വേറെ ആരെയും ചെയ്തിട്ടില്ല, ആരെയും ചെയ്തിട്ടില്ല ഇവിടുന്ന്. പക്ഷെ സാറിന്റെ ഇവിടെ പേര് ലൊക്കേറ്റ്
ചെയ്യണം.
സാർ ഇപ്പൊ അൺമ്യൂട്ടഡ് ആയി.
ഓക്കെ ഓക്കെ. സാറിന് കേൾക്കാമോ?
സാർ കേൾക്കാമോ സാർ? ഗുഡ് ആഫ്റ്റർനൂൺ.
സാറ് കേൾക്കണില്ലല്ലോ.
സാറ് ക്ഷമയോടെ വെയിറ്റ് ചെയ്തിരിക്കുകയാണ്, കേൾക്കുന്നില്ല സാറിന്.
സാറിന് മെസ്സേജ് അയക്കാനും പറ്റുന്നില്ലല്ലോ.
സാറിന്റെ കംപ്ലൈന്റ് ആയിരിക്കാൻ തോന്നുന്നു.
അങ്ങോട്ടേക്ക് മെസ്സേജും അയക്കാൻ പറ്റുന്നില്ല.
Hello, sir. Hello, sir. Cannot hear. Hello, sir. Can you hear me, sir?
രാജഗിരിയിൽ ആരെവിടെയെങ്കിലും വിളിച്ചു പറയണമായിരിക്കും.
I cannot hear. I'm unmuted.
We cannot send message also.
മെസ്സേജ് അയക്കാൻ പറ്റാത്തത്
സാറ് ഹിയർ ചെയ്യാനായിട്ട് ചെവിയിൽ വെക്കണമായിരിക്കും ചിലപ്പം. ചിലപ്പം ഇയർഫോൺ മോഡിലായിരിക്കും.
അതെ, ഇയർഫോൺ യൂസ് ചെയ്താലോ?
ഇയർഫോൺ.
Sir, can you put the earphone?
സാറിന് ആരെങ്കിലും ഒരു ചാറ്റ് മെസ്സേജ് ഇട്ടാൽ മതി. ഞാനൊരു മെസ്സേജ് ഇട്ടു, അത് പോകുന്നുണ്ട്. ആരെങ്കിലും അറിയാവുന്ന ആരെങ്കിലും ഒരു മെസ്സേജ് ഇട്ടാൽ മതി, ചാറ്റ് മെസ്സേജ് ഇട്ടാൽ മതി. നോക്കുന്നുണ്ടെങ്കിൽ കാണാൻ പറ്റും.
Okay, we shall try.
ചാറ്റ് പോണില്ല. സാറിന്റെ ഫോണും എൻഗേജ്ഡ് ആണ്. സാറിന്
സാറ് ക്ഷമയോടെ നോക്കിയിരിക്കുന്നുണ്ട്, പക്ഷെ സാറിന് കേൾക്കാൻ പറ്റുന്നില്ല. മെസ്സേജും ഇട്ടിട്ടും സാറ് റെസ്പോണ്ട് ചെയ്യുന്നില്ല.
കമന്റ്സ് പറയാൻ ആൾക്കാരെ അനുവദിക്കുകയല്ലേ?
അതെ അതെ, അതില് കുറച്ച് ചോദ്യങ്ങളും ഉണ്ടായിരുന്നു കമന്റ്സ്.
ആരോടെങ്കിലും ആൻസർ ചെയ്യാൻ പറയായിരുന്നു.
ഗൈനക്കോളജിക്കാരെങ്കിലും
കമന്റ്സ് പറഞ്ഞോട്ടെ, അവർ പറഞ്ഞോട്ടെ, നമുക്ക് സാറിനോട് പറയാം.
വിജയൻ സാറ് അതൊന്ന് ക്വസ്റ്റ്യൻസ് ഒന്ന് നോക്കിയിട്ട് ഡിസ്കസ് ചെയ്ത് തുടങ്ങി.
പറയാം. യെസ്, there is a question from Dr. Jyoti. The asthma and allergies increase during periods. Is it a hormonal influence? I think the talk was on the problems of mature women after menopause. So the doesn't arise here. But I can answer that in a different way.
Hello.
Yes. Sir, കേൾക്കുന്നുണ്ടോ?
Oh, I see.
Sir,
You cannot hear me?
We can hear.
We can hear you.
But I think he's back.
Oh, I thought the problem is that you are in.
Sir, you are audible. You are, we can hear you.
sir.
സാറിന്റെ ഓഡിയോ ചിലപ്പം
സാറിന് ഓഡിബിൾ അല്ല.
സാറ് പറയുന്ന അങ്ങോട്ട് കേൾക്കുന്നുണ്ട് അല്ലേ? സാറിനോട് ചാറ്റ് ബോക്സിലെ ക്വസ്റ്റ്യൻ ആൻസർ ചെയ്യാൻ പറഞ്ഞാലോ?
എന്നാലും മതി. Yes.
Sorry? Yeah, that's the problem. You can hear me, is it?
Yeah.
Yes.
I see. Okay.
Yes. Sir,
Are you able to hear between you, Mohan and all that? I see. It's only I cannot hear you. Is that right?
Yes. But you are audible, very well audible.
Okay. But let me just see whether I can get the support from the IT here.
ഒരു വെബിനാർ കേട്ടോണ്ടിരുന്ന ഇപ്പൊ എങ്ങനെയൊക്കെ കിട്ടുക?
പോയോ?
പോയി.
ഗൂഗിൾ മീറ്റാ?
അല്ല, സൂം തന്നെയാണ്.
സൂമാ? സൂമിലെ പരിപാടി എനിക്ക് അറിയില്ല. ഇത് പോയോ? ഇല്ല, ലീവ് ആയിട്ടില്ല. ഇത് തന്നെയല്ലേ?
You are still just minimized ആയതായിരിക്കും. നിങ്ങളൊന്ന് വീണ്ടും അത് ചെയ്താൽ മതി. We can hear you. You are still in the Zoom.
Electricity ഒന്ന് വരുമോ? ഇവിടുത്തെ ഓഡിയോയിൽ ഇത്തിരി പ്രോബ്ലം ഉണ്ട്. ഇപ്പൊ തന്നെ വരുമോ? താങ്ക് യു.
In the meantime, maybe Dr. Subhadra. Hello.
I'll just wait for my IT person to come to help with this one and then probably start answering the queries that are posted over there.
Meanwhile, if there are any queries, please post it in the chat box.
Yes. Actually, sir could have started answering one by one, but even though it's only one way. But then how to convey that message?
Shaji, he can hear. If you ask him, send a chat message to him, he might understand.
We sent. Yeah, we sent, but then.
Yeah, we have sent it.
It is not.
Sir.
I'm sending SMS also.
സൗണ്ട് അവിടെ കേൾക്കുന്നില്ല. നോക്കാമോ? ഞാനിത് ഷെയർ സ്ക്രീൻ ഇത് സ്റ്റോപ്പ് ഷെയർ ആയതുകൊണ്ടാണോ? അല്ല, ഞാൻ പറയുന്ന അവർക്ക് കേൾക്കാം, അവിടുന്ന് പറയുന്ന ഇങ്ങോട്ട് കേട്ടുകൂടെ? സ്റ്റോപ്പ് ഷെയർ ചെയ്തോളൂ.
ഇപ്പൊ കേൾക്കണ്ടോ?
അതിന്റെ കുഴപ്പമില്ല, അവിടെ കേൾക്കുന്നുണ്ട്, ഇങ്ങോട്ട് കേൾക്കുന്നില്ല.
ഇപ്പൊ കേൾക്കാമോ?
ഓക്കെ ഓക്കെ.
In the meantime, സാറ് വരുന്നതിന് മുമ്പ് ഒരു കാര്യം ഡോക്ടർ സുഭദ്രയോട് പറയട്ടെ.
Yes, sir.
എനിക്ക് തോന്നുന്നത് നമുക്ക് സാറ് പറഞ്ഞതിന്റെ കാര്യങ്ങളൊന്ന് സമ്മറൈസ് ചെയ്തിട്ടേ എല്ലാ ടോക്ക് കഴിയുമ്പോഴും കുറച്ച് പോയിന്റ്സ് ഉണ്ടാക്കാം ഫോർ ഫർദർ റിസർച്ച്. There is one Shalu Verghese who is assisting academics. I will request her to summarize this, and then we will try to find out some articles which talk about both prolapse, urinary problems, and malignancies, which are prevalent problems in this age group. And then we'll send it over to sir to get his feedback on this. Because the whole idea will be...
Taji, we can hear you now. Can you hear me?
Okay, thank you, sir.
Okay.
Yes, sir.
Okay. Yeah, shall we go ahead with the discussion interaction part?
Yes, sir.
Yes, sir.
Sorry, am I to see the chat box and then do it, or?
That would be better. Or shall we ask Subhadra to read out questions to you?
You could read out the questions.
Can you do that, Subhadra?
Yes, sir.
I will read out questions.
Sure, sir.
You might answer, sir.
There is one question from Dr. Nandini Kumar. She asked whether due to dryness there could be constant infections. Besides the medications, can any other measure help?
What we have found is lubrication of the vagina will help, but very often the dryness alone will not be the cause of infection. Those who are sexually active, what we have seen is that if there is a tightness and sexual activity can increase the chance. Sometimes it may be post-operatively, the vagina is made very tight. That will also increase the chance of infection. What happens is from the anterior urethra, the organelles will be mechanically driven into the bladder, and that can be a cause. In such cases, advice on the direction of the entry as well as lubricants prior to the use may be helpful. Other than that, dryness as such doesn't have to increase the infection. Estrogen deficiency can, to some extent, interfere with the vitality of the epithelium. So it may be tried, but as such, no other cause I can think about. If there is a prolapse, especially cystocele, and emptying of the bladder is not complete, that better be corrected. That is how I will approach it.
Okay, thank you. Thank you, sir. There is another question from Dr. Jyoti. The asthma and allergies increase during periods. Is it a hormonal influence?
I mean, if it is due to, it may be, but as such, it's not a major association that we have found.
Okay, there's another question from Rejita. Why urethral stricture becoming common in menopause? Kindly suggest management.
If it's a urethral stricture, it need not be just associated with menopause. If it's an individual experience, the stricture, what we do is we dilate. Usually the urologist takes care of that. We can dilate the stricture part, and usually dilators like the ones that we use in the gynae side are used by the urologist as well. If it's extremely bad stricture, of course, they may have to resect that part.
Thank you, sir.
So one of the things that we find is of cause for recurrent urinary infection is urethral stricture, urethral stenosis. That's probably what Dr. Jyoti was asking about. Recurrent urinary infection in an older person, we always think of urethral stenosis. Is that hormone related? Is probably what she was asking.
Hormones can have an influence on the entire genital and urogenital area, but as such, present stricture, and if it leads to retention of the urine, of course, then retained urine can be the predisposing factor. Otherwise, stricture itself may be a result of infection of the urethra as well. But other than that, I do not know how urethral stricture alone leads to an infection.
Residual urine. If you have
retention of urine, if you are to empty the bladder completely, of course that can lead to that.
no, but what we are saying is that under recognized possibly.
അൺമ്യൂട്ട് ചെയ്തിട്ട് അൺമ്യൂട്ട് ചെയ്തിട്ട് ഓഡിയോ ഓൺ ആക്കിയത് പറയണം.
Next question, please.
Treatment of dyspareunia in menopause.
Usually, we have to see what it is due to. If it's an anatomical reason like narrow introitus or narrowing, then of course, all these, if it is just the age-related problem, local estrogens can be given. Lubricants during intercourse may be the other thing to be used. These are the two that we have in our armamentarium. If there is any surgery done which has made the introitus very narrow, of course, that has to be made wider, which may usually be achieved by just simple surgical procedures.
There is another question from Rejidar. Is there any role in the measurement of endometrial thickness in the prediction of your ovarian function or estrogen availability, especially in menopausal period or perimenopausal period?
Yeah, estrogen level in the body is reflected in the endometrium ordinarily. So thickness of endometrium is a reflection. With the perimenopausal age or even post-menopause, we do not depend on the endometrial thickness as a reflection of the estrogen. But before menopause, certainly endometrial thickness is a reflection of the estrogen value. That way it can be used. But the measurement of the endometrial thickness is usually used in the post-menopausal age to know whether the endometrium is pathological. Usual cutoff put is 5 millimeter. If it's more than that, then in a postmenopausal woman, that endometrial thickness has to be investigated. I don't know whether I answered the question correctly to the point. Premenopausally, endometrial thickness is reflected by the estrogen value, true, but we don't usually do the endometrial thickness measurement to know that. Postmenopausally, endometrial thickness reflects the potential of malignancy. So that way, it becomes more relevant.
Okay, thank you, sir. There is another question from Dr. Annamma Jo. What about the treatment of urge incontinence? Sir had mentioned about that, but there is a question in the chat box.
Yeah, it's mainly medical management. Usually we use drugs which can suppress the detrusor muscle. One of them is darifenacin. Previously we used to have many others, but there are more side effects. Now we usually use darifenacin for that.
So there is another comment from Dr. Rajmohan, sir. Thanks for the wonderful presentation. In spite of the liberal system support from NHM and revolutions in RCH, especially second and later phases, the quality of life of perimenopausal period is not to satisfactory levels. Preventable morbidity like infections, anemia due to bleeding, late detection of cancer, and sexual health problems remain. Why the government is not giving enough importance to well women clinic in the program mode? That is a question from Rajmohan, sir.
Maybe I think it is to be addressed by the VC and other officials. Professor Mohan may probably say he may know better. But to my knowledge, our emphasis all along had been to acute medicine. And I'm sure soon, Rajmohan, we may probably put more emphasis on a well women clinic as well as such aspects, especially in the Kerala setting. But elsewhere in India, I don't know when it will happen.
Absolutely, sir. Actually, these kind of webinars will give a lot of awareness and the data and with which we can approach the government. Like Well Baby Clinic, we will have similar clinics for postmenopausal persons also. So we have to generate data, and then with this data, we will have to approach the appropriate authorities who will definitely be bound to act. That is what I think. Thank you, sir.
Thank you.
There is another question from Dr. Srikumar and Jesse. A 35-year-old patient with 5 centimeters of mucous fibroid with heavy bleeding, looking for second child. What can be done? This is a geriatric
Yeah,
program, but
the
there is a
question,
question.
because the question has come, I will answer that. This is a clinical setting where there are now simple measures available to get that submucous fibroid removed. This is a little 5 centimeter, a little too big, but still maybe taking 2 sittings or sometimes even with 1 sitting, we can remove that fibroid and give her chance for getting pregnant. Hysteroscopically, it can be done. You approach the fibroid and remove the fibroid alone, and that will take away this problem.
Okay, thank you, sir. I think there are no more questions in the chat box.
Can I say something?
Yeah, sir. Sure, sir.
Sir, one thing, thank you very much for highlighting common problems like prolapse, urinary symptoms, incontinence, malignancies, etc. We propose that we will summarize what you said, what happened during the discussion, and then try to identify areas wherein we need more data or information and report back to you, sir, so that we can take this forward in the next few days to 2 weeks. And then one concern which we have is that this is my personal observation, that there may be underreporting and delayed reporting of problems of gynecological nature in older women because of various reasons, social and otherwise. Thus, lot of preventable reversible conditions might come to the clinician very late, and thus they may not be eminently treatable. This we might want to address, especially in terms of prolapse, urinary symptoms, sexual dysfunction, or things like that. So that's something. So there may be huge treatment gap, especially about conditions which are eminently treatable and prevalent in the community, but then not seeking help. This is a matter of huge concern, sir. We will get back to you in writing, sir. Thank you.
Thank you. Thank you, Shaji.
Thank you. There is one more question. There is a one from Dr. Rajida. Bluish discoloration like petechial hemorrhages as beneath skin becoming more common perimenstrually, even in perimenopausal time. Is there any clinical significance?
When we have petechial hemorrhage, we usually think about, is there any problem either with the platelet function or the vascular function? That is what we think. And it may have to be investigated from that angle. It may not be particularly related to a gynecological issue. That is how I would look at it, actually.
Okay, thank you, sir. There is another question from Yashaswini. AUB in a perimenopausal women nearing 50 years, is it advisable to do FSH to determine if she is menopause?
FSH to determine whether she is menopausal may not be all that productive or that useful, because there's a wide range and duration during which the FSH may change to menopausal range. By the time she is in the late 40s, FSH may start to increase, but she may still be menstruating. So FSH level as such may not be a useful investigation to manage that case. What we do is, depending on symptom, to manage. In a perimenopausal age, of course, the first concern is to rule out malignancy. Once that is done and malignancy is ruled out, in such cases, usually we treat them medically, either with drugs like tranexamic acid to reduce the bleeding, or hormones to regulate the cycle, or insert progestogen into the uterus with devices like the Mirena coil. So these are the approaches to that. FSH measurement as such may not be that rewarding as an investigation to know the cause of this.
I think there are no more questions in the chat box. Does anybody need to ask anything?
Okay, otherwise.
Okay, yes, sir.
Thank you very much. Thank you, Shaji, and all of you for this opportunity. Thank you once again.
ആദ്യം സാർ
Thank you
ഇവിടെ
so much.
കുറച്ച് കുറച്ച് പ്രോബ്ലംസ് വന്നിരുന്നു. ഞങ്ങളുടെ നെറ്റും കുറച്ച് പ്രോബ്ലമായി, പിന്നെ സാറിന്റെയും കുറച്ച് ബുദ്ധിമുട്ടായി. എന്നാലും അത് ഇത്രയും ഭംഗിയായിട്ട് ചെയ്തു തീർക്കാൻ സഹായിച്ചു എല്ലാരും കൂടെ. പ്രത്യേകിച്ച് VC സാറും ഷാജി സാറും കൂടെ ഉണ്ടായിരുന്നോണ്ട് എനിക്ക് അത്രയും ബുദ്ധിമുട്ട് അറിഞ്ഞില്ല. അപ്പൊ താങ്ക് യു സർ. Thank you, VC sir, for granting us permission, and also Shaji sir and all the other participants who were along with us, especially Krishnan sir who made it live, and Rajmohan sir and everybody. Thank you, sir. Thank you for the session. Okay, thank you, sir.